Well, moving on to the next session, there will be three speakers. I'm going to introduce the moderator so that the moderator can come and introduce the speakers. So it's my pleasure to introduce Dr. Daniel King. Dr. King is a gastrointestinal medical oncologist and researcher specializing in pancreatic cancer at Northwell Health and serves as the director of the research and development for the Cancer Institute's Center for Genomic Medicine. His primary area of research is the development of computational tools to identify and navigate patients with new radiographic suspicion of pancreatic cancer. He also recognizes the importance of studying healthcare disparities in his research projects. So please join me in welcoming Dr. King to moderate this session.
Hey, everyone. Thanks, Mauro. What an amazing first session there we had. Now we're going to be moving into 3 talks, each of 25-minute duration, before lunch. And in the first session, we heard a lot from Dr. Newman and others just how important genetics can be. We saw that for the disparities in outcomes among some African-American women seems to be driven in part by genetic abnormalities. We've also learned that in cervical cancer, it's really this access to screening that seems just so imperative to improve outcomes. And here we're going to be speaking a little bit more, first starting off with the importance of genetics, and then moving into environmental risk reduction, so exposure reduction that we're going to be seeing in order to try to drive down incidence and hopefully outcomes to improve outcomes as well. So we have 3 talks. I'll do introductions for each speaker individually. The first speaker for today, the talk is entitled Cancer Genetics 101. It's going to be given by Ms. Aman Man. She's a certified genetic counselor and manager of the Cancer Genetics program at the Northwell Health Cancer Institute. She has advanced training in medical genetics, specifically in cancer genetics, psychosocial counseling, and she also works closely with patients and families to assess hereditary cancer risk, guide genetic decisions, and expand access to genetic counseling services. I will say, on a personal note, I work very closely at Northwell Health with Ms. Mann. I'm so pleased that she's going to be speaking today to lead off this session. So without further ado, please welcome Ms. Mann to the stage. Thanks.
Awesome. Hi, everyone. Good morning. My name is Amin. I'm a cancer genetic counselor at Northwell Health. No disclosures. I like to start my talks the same way I start genetic counseling sessions, with a basic what are genes conversation. So to start off with, everybody has 2 copies of every gene in your body. You get one from your mother and you get one from your father. That's typically what we should have. And that includes all the genes we talk about in the cancer gene spectrum also. So if we think about the BRCA genes, everybody has the BRCA genes. You're supposed to be born with 2 working copies of it. So when we kind of think about cancer and we put a genetics lens on it, I can almost divide all cancers up into 2 buckets. The first bucket is that the cancer is happening sporadically. So it's a combination of our environment, our lifestyle, our age, and that's 80 to 90% of cancers. So the way that kind of functions is that an individual is born with 2 working copies of the gene, but during the process of division and multiplication, a random mutation occurs in one of the copies. That's still okay because we still have a second copy of the gene that protects us from developing cancer. But as it continues to divide and multiply and the process goes on, you may have a second mutation that happens in the second copy of that gene, and that's when you can have something like cancer develop. What's different between sporadic cancer and inherited cancer is that an individual is already born with one of their copies of the gene not working. So they're born with a mutation in one of these genes, so they only need one more random mutation to occur for a cancer to develop. Although this is not the common scenario in most cancers, it does account for 5 to 10% of cancers. We do say they are inherited or due to a hereditary predisposition syndrome. And there's several different ones. You may have heard of the BRCA genes that are associated with hereditary breast and ovarian cancer. But these are just a few other ones that you may have seen in clinic or in other patients. It's definitely not an exhaustive list. There's many, many, many different syndromes that we can see, but these are just some of the common ones that you may come and see in your own specialties. So now that we know 5 to 10% of cancers are inherited, how do we actually find those that have an inherited mutation when we see a patient in clinic? So it starts with the genetic risk assessment, which is what I do every day, all day, which is one, it encompasses 4 different things. So first is the assessment of the personal history. What kind of cancer does the individual have? At what age were they diagnosed? The second piece of it is a family history. Who else in the family has cancer? What kind of cancers do they have? Is it on the maternal side, the paternal side? And how does that relate to your patient's cancer? And then the third is the pathology. The pathology of the cancer is very important. We spoke about earlier how triple-negative breast cancer is actually more so associated with germline mutations, especially in the BRCA1 gene and other genes that we see. So knowing the pathology, the hormone status, the type of cancer it is, does play a role in our risk assessment and what kind of testing we do for a patient. And then the fourth, which is what we usually jump to, which is genetic testing, is a part of the risk assessment. All of these, importantly, are genetic risk assessments. You need to do all of them, essentially, to be able to do a complete risk assessment. But the first 3, in particular, the assessment of the personal family history, and then the pathology, should be done for every single patient that's diagnosed with cancer to, one, assess if a further evaluation is needed and if genetic testing is indicated. So just a few things about collecting family histories. It's a cumbersome task sometimes to get a full 3-generation pedigree. I do it for every single patient that I see. So I draw a tree for every single patient to get a full picture of everything that's going on in the family. But it is time consuming. Just so you have an idea, our initial genetic counseling visits are scheduled for an hour for each patient. And a good chunk of that goes into just collection of family history, personal history, and just data intake. So genetic counselors are kind of trained in this, and we do help physicians try to do this. So we're not taking away from their clinic time, but there are other physician extenders that can help with obtaining a full family history. What we were talking about how primary care providers just don't have enough time to do all the things that we need them to do and collect all the family history that we need to be able to assess if someone needs to be referred to genetics or not. A quick family history screening that we usually recommend at the first visit is just asking, does anyone in your family have a diagnosis of cancer? Parents, grandparents, siblings, aunts, uncles, or first cousins, and primarily focusing on breast, ovary, uterine, colon, pancreatic, and prostate cancer. The other key point is that you don't just want to take a family history once. Cancer diagnoses occur over our lifetimes, family history changes, so our assessments that we do are based on the information we have in that moment. So today they may not meet criteria for genetic testing, but in maybe 2 or 3 years, there's a new diagnosis in the family that makes us suspicious, so then we want to make sure they're being referred to genetics. But of course, like everything, family history has its limitations. So if there's a small family, they don't have any siblings, no aunts and uncles, or if there's just not enough female relatives, especially when we're assessing for genetic syndromes that involve female breast cancer, or ovarian cancer, or uterine cancer, if there's just not enough females, we're not going to be able to see a family history that's suggestive. And then, of course, if the patient is adopted and doesn't know their biological family, or if there's non-paternity. So once you've collected the personal history, the family history, and you have this nice, beautiful tree in front of you, how do we actually determine if this is actually suspicious for an inherited syndrome? So there's a few different things we're looking at, and I call them red flags when I describe them to patients as well. But we're looking for early ages of diagnosis. So anything diagnosed under 50 typically for most cancers is considered early, so breast cancer, colon cancer, endometrial cancer. We're looking for the same type of cancer in 2 or more close relatives on the same side of the family. So they're either on the mom's side or on the father's side, and that's what we're looking at. And then we're looking for a combination that makes us more suspicious of certain cancers. So if we see colon and endometrial cancer running in the family, then we're getting a little suspicious maybe of Lynch syndrome. If we're seeing breast and ovarian, we're thinking maybe the BRCA genes. And then if we see multiple primary tumors in an individual, if they have bilateral disease, those are also suspicious findings. And then if we see single cases of certain cancers that we just tend to see a higher proportion are inherited, so this could be high-grade serous ovarian cancer tends to be more than that 5 to 10% that I mentioned before that tend to have a gene mutation. Medullary thyroid cancer, pheochromocytomas, paragangliomas, there's a whole slew of them that if we see them, we want to be thinking about genetic testing. So there's many, many, many guidelines that are available. I'm just going to brief through this just so you have an awareness of where to find it, but we're not going to focus on it too much. I want to take too much time just focusing on that piece. But this is the ASBRS. The American Society of Breast Surgeons did come out with this statement in 2019 saying anybody diagnosed with breast cancer should be offered genetic testing. And this could be done by the surgeon, by referring to a genetic counselor or any other advanced genetics provider. The NCCN guidelines, the National Comprehensive Cancer Network, does have a lot of consensus statements about testing criteria for individuals with cancer that are a great resource if you're not familiar with when to test, when not to test, or if you should refer to a genetic counselor. This is for particularly breast cancer susceptibility testing. So just to highlight a few things on here, anyone diagnosed under the age of 50 or 50 and under, if it does impact treatment decision-making, so we do know things like PARP inhibitors have become a conversation for patients that have metastatic breast cancer. If they have triple-negative breast cancer, if there's lobular breast cancer, male breast cancer, if that's a rare cancer, if we see it, we're more inclined to do genetic testing. And then if we do see certain ancestries, like Ashkenazi Jewish ancestry. Other ones, quickly, epithelial ovarian cancer. So if you see high-grade serous ovarian cancer, you immediately want to be thinking about genetic testing. If you see exocrine pancreatic cancer, if you see metastatic prostate cancer or high-risk or very high-risk prostate cancer, this is still relatively new. There's still uptake that's happening in this, but hopefully we'll kind of get more referrals in that space. And then this is for Lynch syndrome evaluation, which is primarily a GI and GYN cancer syndrome. In this, once again, similarly, anyone diagnosed under the age of 50 or under, and that could be any Lynch-related cancer, which is colon, endometrial, or other GI cancers. If they have synchronous or metachronous Lynch syndrome cancers. And then an important piece that I highlight in this guideline is that they do talk about tumor testing. So tumor testing could be genetic testing, or it could be immunohistochemistry. We do mismatch repair protein testing, immunohistochemistry, or MSI instability in all colon endometrial cancers to assess for concern for Lynch syndrome. And more we're doing somatic tumor testing on tumors to see for clinical treatment options, but also sometimes we're incidentally picking up germline mutations. So that's a good reason to refer to genetics as well. Because I've had patients that have lung cancer, did somatic tumor testing, there was a BRCA1 mutation identified on the tumor, and then they're referred to us to determine if it's truly germline or not, and sometimes it is, and so now we have incidental BRCA1 or BRCA2 mutation that now impacts the patient for other future cancers, but also their families. And these are just other cancers that if you see them, you definitely want to be thinking about genetics. Some that I noted here, medullary thyroid cancer, paragangliomas, and pheochromocytomas, which are rare endocrine tumors, adrenal cortical carcinoma, and a few others that are listed here. But once again, not exhaustive, just to kind of put it out there, what we're looking at and things to keep in mind. So once you've determined who needs testing, you've done the appropriate testing, what is the reason we're doing this, and how does it actually impact patients? So one, it can impact immediate treatment options. So we do see a clear impact in certain genes, so BRCA, TP53, RET genes. It could impact risk reduction strategies in survivorship and for unaffected individuals that have a gene mutation. It impacts research, and then it also impacts cascade testing, which we'll talk about in a little bit. So one example that I just wanted to go through, since this is usually the one most people have heard about, is BRCA1 and 2. It's primarily associated with breast and ovarian cancer, but is also associated with pancreatic cancer, male breast cancer, prostate cancer, and there's some data to suggest that it might also be associated with melanoma. So just to highlight primarily the breast and ovarian cancer risk, because that's really the highest risk that we see with BRCA mutation carriers. So this is from a paper in 2017 where they did a prospective study on almost 10,000 mutation carriers. And you'll see on the first table, on the first graph on the left, for BRCA1 carriers, so individuals that were born with one copy of the BRCA1 gene not working, the cumulative lifetime risk of developing breast cancer to the age of 80 is anywhere from 65 to 79%. With BRCA2, it's around 61 to 77%. And importantly, up to the age of 50 is 39 to 48% for BRCA1, and then 29 to 41% for BRCA2. So we are seeing a lot of breast cancer in early ages. That's one of the indicators that there might be something inherited. Because they have that one copy of the gene not working, they just need that second hit, so we can see that happening at earlier ages. With ovarian cancer for BRCA1, lifetime risk to age 80 is around 36 to 53%, and an 11 to 20 5% for BRCA2 carriers. And then to the age of 80, less than what we see with breast cancer. We tend to see breast cancer at later ages, but we can see ovarian cancer, but not so much as breast cancer. But to the age of 50, it's 6 to 12% for BRCA1 carriers, and then 1 to 2% for BRCA2 carriers. So these are not insignificant numbers. These are very elevated risk compared to the general population risk, which right now breast cancer in the general population is around 13% lifetime risk. So these are significantly higher. The other piece that this paper that I really like highlights is the risk of developing another breast cancer in the future. So for our patients that have a breast cancer diagnosis, and maybe that's the time they got genetic testing, this table I use a lot in my discussions with these patients to see what is the risk of them developing an unrelated contralateral breast cancer in the future. And what that sometimes helps with is decision-making in terms of their current treatment of whether, for example, they want to pursue a risk-reducing bilateral mastectomy instead of pursuing a lumpectomy for the cancer that they have. So you'll see here for BRCA1 carriers, if they're over 15 years out of treatment, their cumulative risk is still 35 to 45% for that second unrelated primary breast cancer. A little bit lower for BRCA2, but around 20 to 33%. So not an insignificant number to consider when you're thinking about what makes the most sense in terms of your surgical options. And this table just highlights, and it's very big picture, it doesn't go through ages and the frequency of doing screening, but I really just wanted to focus on the fact that if you know you have a gene mutation, there are risk-reducing options that we do discuss with patients. So I kind of divided the BRCA1s into screening versus prevention. So for breast cancer, one modality is doing screening. We know the combination of mammograms and breast MRIs are very good at picking up breast cancer for high-risk individuals, more so than just mammograms by themselves. And then individuals that do have a BRCA mutation, we do talk about risk-reducing bilateral mastectomy. Of course, it's not 100% risk reduction. There is always a residual risk, but it does significantly reduce that number that I just presented on the previous slide. For ovarian cancer, unfortunately, it's a very different conversation. We don't have the same screening methods that we have for breast cancer that actually are effective and good at catching cancers early. So we actually talk about risk-reducing salpingo oophorectomy, which is the removal of the fallopian tubes and the ovaries to reduce that risk of developing ovarian cancer. There is some newer discussions about doing salpingectomy, which is just the removal of the fallopian tubes, and doing the oophorectomy later. This is more so an option for premenopausal women to reduce the menopause effects and those things that are that removing the ovaries and the fallopian tubes will put you into menopause. So because of the way we think that ovarian cancer occurs, they think if you remove the fallopian tubes, that reduces the risk, but at the end of the day, the standard of care is still to remove both the fallopian tubes and the ovaries eventually. So even if this is being done, and it's mostly being done in clinical trials, we have one at Northwell where they're enrolling patients to see if this is something that we can do for all patients. There is a slight increased risk of serous uterine cancer, more so with BRCA1 than BRCA2, so there is a consideration to discuss hysterectomy, so the removal of the uterus at the time of removing the ovaries and the fallopian tubes. And then, of course, there's other non-surgical and screening-related prevention methods that we can talk about in breast and ovarian cancer, like chemoprevention or estrogen and progestin contraception as well. And then for male breast cancers, mostly screening. There's really no recommendation for doing risk-reducing surgeries. But for some males, especially if they have a BRCA2 mutation, we do talk about even considering mammograms for them, even more so if they have gynecomastia. Prostate cancer, PSA testing primarily, and pancreatic cancer screening, although investigational, there are some guidelines through the CAPS and through NCCN that does talk about what the best methodology is for screening for high-risk individuals, high risk being those with gene mutations and a family history, and the two methodologies primarily used are MRCPs and endoscopic ultrasounds. One of the possible impact genes that I like to highlight is this gene called CHEK2. There's several founder mutations in this gene, so it does come up a lot with genetic testing, but my main reason for bringing up this particular gene is sometimes it's not just knowing what gene mutation you have, it's knowing exactly the type of mutation it is. So not all mutations or changes in the gene lead to the same risks. So with CHEK2 particularly, there's low penetrance variants and there's high penetrance variants, meaning that there's certain changes in the CHEK2 gene, two of them highlighted at the bottom there, the I157T and the S42AF, which are European founder mutations. actually result in a much lower risk of breast cancer than we initially thought. But the high-risk mutations, which are usually truncating, like 1100-delC, tend to have a little bit of a higher risk of developing breast cancer. With those high penetrance mutations, we're in that 23 to 27% lifetime risk, whereas with the other low penetrance ones, they're likely closer to general population risk, if not slightly increased. So that does impact our discussion with patients of whether it makes sense for them to be doing high-risk screening. Is mastectomy an option? Usually with CHEK2, we don't recommend pursuing risk-reducing mastectomy just in this finding of a CHEK2 variant, but we do talk about doing mammograms but considering breast MRIs, especially if it's one of those high-risk mutations. And then just quickly to highlight Lynch syndrome. So Lynch syndrome is a clear impact gene syndrome. It's associated with 5 different genes. They're all mismatch repair genes. This is just one of them. I just put in the NCCN kind of risk numbers for the MLH1 gene, which tends to be the highest risk syndrome part of our highest gene, in the Lynch syndrome spectrum. The primary cancers that we see are colon cancer, endometrial cancer, and ovarian cancer. So colon cancer, you can see general population risk is around 4%, but if you have an MLH1 gene mutation that you're born with, it can be anywhere from 46 to 61%. And then you do see that the age of presentation is younger also. So and average age is around 44 for MLH1. So it is much younger than in the general population. And then for endometrial and ovarian cancer, significantly increased over the general population as well. So we do talk about now, when's the best time to start colonoscopies? How frequently should you be getting colonoscopy? If we know you're at an increased risk, we want to be making sure we follow you and manage you, knowing to the best of our knowledge what that risk is. So for MLH1, for example, we actually start doing colonoscopies in the early 20s, so 20 to 25. Sometimes we even start earlier if there is a family history of very early onset colon cancer. And we do them every 1 to 2 years. So we're not waiting that 5 years, that 10 years for what we do typically in the general population if you're at average risk. So we do want to make sure you're getting those screenings more frequently and seeing a gastroenterologist and being followed carefully. And then for the endometrial and ovarian cancer, we do talk about risk-reducing options there similarly like we did with the BRCA gene. And these are usually discussions that we have in conjunction with our GYN oncologist, and we loop them in and we make sure our patients see them to talk about the pros and cons of surgical risk reduction and also about the importance of follow-up after that. So this is I just put this in just to point out there's a lot of, when we think about precision oncology, germline genetics is a big piece in it. There is now certain therapies that our physicians are using in order to treat certain types of cancers. So there's PARP inhibitors that we know we're using in breast cancer patients that are metastatic and have a germline BRCA mutation. We're doing it for metastatic prostate cancer patients also. We know individuals that have Lynch syndrome or microsatellite instability, immunotherapy works better for these patients. So there's a lot of ways that germline genetics is also playing a role in treatment decision making. But since the oncology team does most of this discussion, I'm going to forward a little bit to more of the genetics piece and what we deal with. Once we've identified a gene mutation in an individual, the next step for us is discussing cascade testing and family members. So most of the cancer genes we talk about, like the BRCA genes, are primarily inherited in an autosomal dominant fashion, which essentially means that if you are born with 1 of your copies of the gene not working, there's a 50% you pass on that non-working copy of the gene, or 50% you pass on the working copy of the gene. So we then want to talk about testing children, because there's a 50-50 chance that your child could also inherit this. There's a 50-50 chance your siblings could have this, same thing as your parents. And then we kind of go down, start talking about aunts and uncles once we know which side of the family it's on. So it's not just the patient when we see in genetics, it's about the whole family. Other implications just to make you aware of, if we do have young adults that are found to have gene mutations and they are planning on having children, there is the option of pre-implantation genetic diagnoses, or PGT, that's done in the process of IVF, where they can test the embryos prior to implantation to prevent the passing on of that germline mutation. It's an option that we discuss with all patients. It's up to them if they choose to pursue it or not. If they do, we do refer them to our fertility genetic counselor who goes through the logistics of that whole piece. We do also want to assess for potential autosomal recessive risks for children. If, for example, there is a BRCA mutation in both parents, if they both have a BRCA2 mutation and they both happen to pass on that non-working copy, you could have a pregnancy that has two non-working copies of the BRCA2 gene, which we have seen case reports that if that does result in a term pregnancy, a child could have a completely unrelated syndrome called Fanconi anemia. So we do talk about that in our results discussion, in our post-test counseling about potential other risks that could be occurring. And so we talk about testing partners, and that's all within our scope of practice. And then speaking of children and testing them, most of these cancer genes are adult onset conditions, so we don't actually test children until they're over the age of 18. There are exceptions to this rule. There are certain syndromes that we do see childhood cancer. So individuals that have a TP53 mutation, for example, they have Lee-Fermini syndrome, we actually do see childhood cancer. So they actually start screening, within a few months or few years of life. So in those cases, of course, we're testing at much younger ages. And one thing that I like to mention to any individual that's getting genetic testing and doesn't have a personal history of cancer is this federal act called the Genetic Information Non-Discrimination Act, or GINA. It talks about what federal protections we have against discrimination based on our genetics for health insurance and employment. Those are protected, but it does not protect against life insurance, long-term care, and disability insurance. So for our younger patients or patients that don't have these policies in place, this sometimes does play a role in their decision-making of pursuing testing or not. So how do we actually incorporate a genetic risk assessment into our clinical care? Everything that I went through so far, it's a lot of information to provide patients pre-test and then post-test as well. And even though we do know that we should be doing genetic testing for certain indications, and it's been published and it's been kind of a consensus guideline, we don't see that every patient that needs to get genetic testing is being referred. And it's particularly, we see it even more so in individuals that are of African American descent. The uptake in actually doing genetic testing, per the study that was published in 2008, is 58% of African Americans underwent genetic testing compared to 71% of white women, despite being aware of the genetic testing. It's not that there's not interest, it's just that the follow-up is not happening, and a lot of it may be attributed to just not being referred, not being educated about the fact that this even exists. Most people that I meet, even within the healthcare setting, don't know what a genetic counselor is, doesn't know that we exist in this system, so a lot of it does have to do with education. But this, just quickly, this in 2021, this study just looked at kind of the trends in genetic testing in ovarian cancer patients, which I had mentioned. Anyone with ovarian cancer, you want to be talking about genetic testing. But you'll see that line in the middle there, it's been pretty consistent since 2013 to 2017, so around that 35 to 40% mark of where we're getting tested. The only thing that we see more of a significant change of is that we're not just doing BRCA1 and 2 testing, we're now doing multi-gene panel testing. So we're not just doing BRCA because we've discovered several other genes associated with breast and other cancers and ovarian cancer as well. And then this one particularly looked at germline BRCA testing in around 13,000 patients with ovarian cancer and commercial insurance. And this one I like particularly because they kind of highlighted key moments in the pathway of genetic testing. So the A is when NCCN, those guidelines that I brought up, said we should be offering genetic testing to all patients with ovarian cancer. So we do see an uptake of the rate of the BRCA germline testing being offered. And then when PARP inhibitors received FDA approval for treatment of recurrent disease, we kind of see another uptake there. Not so much when we got the FDA approval for maintenance therapy, but generally we have seen an uptake, but we're still kind of at that 55% mark of getting everyone tested when we should be essentially offering it to every single patient. So we should be closer to 100%. And just at Northwell itself, we see around 25 to 3,000 peridiagnostic breast, ovary, prostate, pancreatic cancer patients that should be offered genetics. We don't have the capacity in a lot of our community providers to do these risk assessments, but then we refer to genetic counselors, but there's not a lot of cancer genetic counselors nationwide also. There's around 1,000 cancer genetic counselors nationwide, and just at Northwell, our team is 8, including myself. So, and our team in particular, and Dr. King's team has actually been a big part of this, is we've started this germline genetic education and testing initiative where anybody diagnosed with a new diagnosis of breast cancer, pancreatic cancer, and ovarian cancer is being, at their first visit, is being offered a streamlined process. Either if they're offered it and the patient is interested in pursuing the testing, they watch this educational video. It's around 7.5, 8 minutes, and it covers a wide range of important aspects that we need to be covering before we can get informed consent from a patient to do the genetic testing. So it covers basic genetics education. That slide that I had in the beginning with the mother and the father, that's from the video. It includes the pros and cons of testing. Why is it something that's being recommended to them by the provider? And then it does include verbiage on billing, because we know that's a big inhibitor for genetic testing. It's the cost of the test and not knowing what you're walking into when you do a lot of this testing. So all of that is actually covered in that video, and there is the option to still meet with the genetic counselor, so they can still decline and then meet with one of us, or they do the testing through the clinic. Once the results come out, the oncology care team gives out the results, but if they're positive or if there's still a concerning family history, they're referred to our team at Cancer Genetics, and then we see them for a full evaluation to make sure we're covering any other additional recommendations or any additional testing that we need to do, because specifically, this test is for the cancer type that they have. So if they have breast cancer, we're really only testing for breast cancer genes. If they have pancreatic cancer, we're only doing pancreatic cancer gene. It's not meant to be a complete genetic evaluation. It's supposed to provide the important information that the oncology team needs to make treatment decisions for that moment. And we're trying to do it at a faster rate and doing it quicker, because we know we don't want to delay treatment based on genetic testing results. So this is, we started this in 2023, and then this is up until the end of 2025. So we now have over 1,400 patients that we've tested through this streamlined process. So that's a lot of patients that otherwise may have had to wait to see one of us or may have not been referred at all. And sometimes doing it at your first visit and doing everything at once, sometimes easier for patients rather than going to different centers and different appointments. It's a lot when you're newly diagnosed to then be like, now you have a genetics appointment, now you have a nutritionist appointment, now you have to go see this person. So it actually has been very good for our patients. And I do want to thank our genetic counseling assistants and our providers that are doing this with us, because we wouldn't have seen this uptake without them being a part of that. I kind of mentioned in the beginning when we talked about just referrals to genetics and how we do see a lower uptake in African American individuals. A lot of our genetics information is based on the white European population. Our Human Genome Project, which was kind of the big catalyst to being able to do a lot of cancer genetic testing, was 80% white European individuals. So we don't know what's the baseline for a lot of individuals that are African American descent, South Asian, or any other descent. So what we do find is the individuals that do end up pursuing testing, despite, maybe they found their own path to us or whatever the case may be, by the time they do get the test and they actually get results, we see a lot more uncertainty in the results. We get these things called variants of uncertain significance, which are a little bit harder to understand and clinically interpret for the patient. So hopefully, as we get more individuals getting tested and we have more diversity in just our baseline information, we'll have a lower rate of these uncertain findings. So if you do have patients that need to be seen by us, I just put in our information here. We do have genetic counselors in Queens, in the city, Staten Island, Westchester, and Long Island. Oh, and I just wanted to show this one. This is a Center for Prevention of Women's Hereditary Cancer Services center that was just opened at Glen Cove Hospital at Northwell. There's different services that they provide. One of our genetic counselors is a part of this clinic. We provide surgical counseling, high-risk screening, menopause specialist support groups. And this is just an event that I wanted to highlight that's coming up on March 25th for any individuals that are previvors, essentially that are unaffected, have a gene mutation, and want to connect with other previvors. And then there's going to have a special presenter, Dr. Volk, who's a plastic surgeon. And just some acknowledgments, and thank you so much.
Thanks very much. Mine, that was fantastic. Some striking statistics there about inheriting BRCA mutation, increasing your risks by 1/8 to greater than 1 in 2. So, but not only is there risk there, but what you can do about reducing your risk. So I like that angle. We're moving on now. Talk about a different type of risk. This is exposures. We're going to be talking now about vaping, smoking, and lung cancer. For the next speaker, Dr. Bittoni. Dr. Bittoni is a research assistant professor in the thoracic oncology program at Ohio State University Comprehensive Cancer Center. Her research focuses on lifestyle factors such as smoking and vaping, diet and exercise, and their role in lung cancer prevention and outcomes, especially interested in the effects of the inflammatory biomarkers on lung cancer risk and their interrelationships with the microbiome. So please welcome to the stage, Dr. Bittoni.
Hi, everybody. Great to be here. Thank you for Laura and everybody who was involved in setting up. And you can hear me okay. So yes, happy to be here. Hadn't been in New York City since like pre-COVID, so it was really kind of nice to be back and fun to be here. So I am switching gears a little here today with vaping, smoking, and lung cancer risk. So vaping, most of you are familiar, has increased in prevalence these days lately, especially among young people. It involves the inhalation of a heated aerosolized liquid that delivers nicotine, and versus like smoking, where there's a combustion of tobacco. They're actually getting this through the aerosolized liquid in this vaping pen, and it results in known carcinogens. So there were very few published studies. Really, I believe we were the first in 2024 to publish this study where we examined the risk of lung cancer in cigarette smokers compared to those who vape. It turned out to be in combination with those who vape, but I'll explain more how that happened. So the current study examines the risk of lung cancer with vaping and cigarette smoking, and this was published in 2024 in the Journal of Oncology Respiratory Therapy. And along with colleagues, my colleagues who have been longtime colleagues and mentors, Dr. David Carbona and Dr. Randy Harris. All right, now let's see. Sorry. Okay, the next slide. Many of you may also know that 87% or close to that of lung cancers can be attributed to chronic tobacco smoking. So only, like we could say 13, 14% that are non-smoking related. So a lot of them are related to smoking. We know it's a big problem. Smoking cessation programs are difficult. So a lot of people did switch to vaping, and it was thought, especially in recent years, it has been promoted. E-cigs have become very popular and promoted as being possibly safer than cigarettes, what is also known as the harm reduction approach. So a lot of people did switch to vaping, and that was maybe partly through the tobacco industry, but maybe even physicians, people that don't know. The reason also is that there's, just no evidence, and there's no evidence that it's safer or more harmful, or at least there hasn't been much evidence. But the aerosols that are contained in these vaping contain toxic chemicals still that have been shown to cause airway restriction and inflammation in the lungs. So, okay, next slide. So the use of e-cigs, like I said, is a little bit redundant here, but partly has been promoted, especially by the tobacco industry, despite the lack of evidence. So, no evidence is like, okay, green light. We don't know it's harmful, but we, have to be cautious, and we really do want to know, is this going to be harmful? Because as we know, cancer doesn't just develop overnight. I mean, it takes 10 to 20 years. And when you think of the number of youth that are vaping these days, it's so prevalent. So we really want to know. It's really important to study this. The reviews and meta-analyses suggest that e-cigarettes may help some smokers quit or reduce smoking, but the results have been limited and small, inadequate, or just not very methodologically sound studies. So more research is definitely needed. I do know there's some study. I remember a study that showed that the vaping may not, the toxins may not reach, as bad as the cigarette smoke, but that also wasn't, very certain. And I just remember one study like that. But pulmonary function studies show that e-cigarettes use results in the immediate increase of airway resistance, inflammation, exposure, and also there's exposure to other harmful chemicals such as the nicotine. They're getting nicotine, humectants, aldehydes, flavor, and then there's flavoring agents, other chemicals, amines. There's a huge list in our paper, so if you want to know more. So the e-cig use does lead to a marked increase in secretion of pro-inflammatory cytokines in the upper airways and lungs, which may increase or heighten the risk of lung infection, pneumonia, and other lung diseases, such as cancer, which is what we decided looked into for today, this talk. So our study design, the ideal study is obviously to do a long-term study where, you look at, groups of vapors and then a group of smokers and then non-smokers, and then you go long-term. Well, that takes 10 to 20 years. Like I said, it takes a long time for lung cancer to develop. So what we did is we went back, did a case control study where you have your existing cases, and then you try to find a comparable group. So we match and try to do a matched case control study. And so that way we could still look at the risk of lung cancer that was associated with vaping and smoking versus cigarette smoking alone. That's what we ended up having in our groups because our cases, so this was all from our electronic medical records at the Ohio State University James Cancer Hospital. And we found 4,975 newly diagnosed, histologically confirmed lung cancer cases from 2013 to 2021. And then for our controls, what we looked during the same period, and we had 27,924 controls without cancer who were group matched to these cases of an approximate ratio of 5 to 1 by race, gender, year of ascertainment, and location, so zip code. So we had 5 controls per case, and then you want to match, so you want to make them as comparable as possible. They were, these were non-cancer cases. Non-cancer controls. For our statistical analysis, we use the logistic regression method models to estimate odds ratios, 95% confidence intervals, to look at the cigarette, smoking, vaping, and other potential risk factors. And then we adjusted, these were matched on age, sex, and race already, but we still, put that in. So men, and then looking at separate estimates, shall show for men and women, distinct histological cell types, and pack years, and then also looked at the comorbidities of coronary artery disease and chronic obstructive pulmonary disease, or COPD, to look for effect modification, the effect there. So our first table here is these are the demographic and clinical characteristics of the cohorts, the cases and controls that we looked at. And so if you see, since we did match, we did end up with a little bit of higher number of older controls, more in the over 60 range, and about 70% and 60% were of the controls were over 60. So it does make sense that the cases are older, and lung cancer average age is 60 and up. Then for gender and race, really they were well matched. They were very well matched. So no differences there. And then I want to talk about pack years, because we know pack years are important because we want to know how long they smoked. Again, this is medical record data. Medical records were never really intended for research, but because, there's so much data in there, we do try to use it. So we have to make do. And sometimes, especially with this topic, because, the smoking, we had about 10,000 out of the whole sample that did answer about their actual frequency, where we had enough information where we could actually try to estimate the pack years, because that's the variable that we really want to look at as far as the duration of exposure. Smokers had a medium level of exposure of 40 pack years with an interquartile range of 20 to 60 pack years, and the cigarette smoking was reported by 89% of cases versus only 38% of controls. So definitely more people smoke with lung cancer. But reciprocally, almost 2/3, 62% of controls reported never smoking versus 10% of cases. That's expected. And reported vaping also was nearly 8 times higher, 8-fold higher among cases compared to controls, so that was significant. And over 97% of those who vaped also reported becoming smokers, or at some point they also smoked. So we'll get to that again, but here now we're looking at the estimates of effect, the odds ratios, or which can be estimated as risk ratios in cancer because it's a rare disease. So for the vaping group, so you see the odds ratio there at 57.8. So that's huge, really astronomical odds rate. That was basically a crude odds ratio. So that was for people that both vaped and smoked. Just looking at that, but does take into account the age, gender, and race. So for cigarette smoking only, the risk ratio or odds ratio was 14%, 13.9. And then obviously no exposure was our reference group. So we were really shocked by this. We really did not expect this. I mean, we didn't know what our information, how much we would get on this vaping, and almost didn't even expect a difference because we just didn't know how much. So this was, pretty surprising. Here now, these are all the stratification estimates that we did, and here you see they do go down a little. So for people that had coronary artery disease, the odds ratio was 48, still pretty high. For COPD, it was down to 29 or 30, almost 30. And then for when we looked at both, it was 38.7. So we kind of did that because that kind of averages the two out. So really, these are the estimates we went with. Pretty much was the 38.7 and the 9.6. Okay, and 9.6 for the cigarette smokers. Now, a risk ratio of 9.6 or 10 for cigarette smokers only is very common. So that, that really is, was not surprising. But the risk ratio of 38.7 was very high for the vaping. And now this is dual use, so we know their risk is being multiplied. So it's almost like synergistic. Like if you're looking, back when they were found, asbestos, and if you smoked and were exposed to asbestos or like radon, high radon. I mean, it's like synergistic. So we're seeing these huge risk ratios. For men, when we looked at this, is just stratification. Men, it was really high, 70. Women was 46, and then for histology, 20, 46. It was higher for squamous than adenocarcinoma was lower. Large cell versus small cell, it was on a range of 55 to 60. So those were the stratifications we did. And then, so we did look at pack years, because again, we didn't have the whole sample, so we didn't. So when we stratified, we looked at the median of 40 pack years. Now, that's really high. 40 pack years is the equivalent of 1 pack a day for 40 years, or 2 packs a day for 20 years. Or so that's really high. It was like 68. And then for the people that were less than 40, it was still high at 30. But for smokers only, it was high, but you would expect greater than 40 pack years. It would be high for anybody, so it was almost 20. But for the smokers only, it was 8.8, which again, we look at those 8 to 10 is probably pretty common with smokers, so that's not that unusual. And then, the other thing I wanted to point out when you, with those earlier tables, when you're looking at the difference, one thing that was always consistent, and I think I'm actually going to go back because you see it better when you look at this way. Every single one of these was 4 times higher for the vapors, for the vapors and smokers in combination versus just the smokers. So if you multiply times 4, every single one of these. So it was very consistent that no matter how we looked at this, it was always 4 times higher for the vapors and smokers combination versus just the smokers. And so this kind of illustrates that. It's a little bit harder to tell, but well, of course, these were the stratifications. Some of these were more or less, but when you look at the total, 10 and 40. So that was one thing that we did find as well. Here we did a sub-analysis with just for age. So looking at early onset lung cancer has been a lot more prevalent in recent years, just like colorectal cancer and other cancers. So we definitely, we wanted to look at this subset. Now, the vapors, tend to be younger. So, and they're diagnosed, and the lung cancer cases are usually older. So we didn't have as many, but we did have enough to do this analysis. So at 256 cases and 2,946 controls, same they were matched. Everything was the same as before. So you see here that the odds ratios did decrease quite a bit. So it's down to, down to 13 for the dual use of vapors and smokers. But those people who only smoke were 5, was down to 5. So these, like I said, it makes sense too, because we don't have as many vapors and you have vapors, but not as many lung cancer cases. So you would see that decrease. And then looking again at the same type of analyses, the stratifications with COPD, we had actually a lot higher for the CAD, the coronary artery, versus the COPD. Versus the smoking. I think our estimates, though, when we combined, were about 14. So our final estimates we went with 14 and 5, I believe, were the final estimates, final model estimates. Again, on gender, much higher for men as usual, and about 10 and 4 for females. And then for the adenocarcinoma, that was so prevalent that was the predominant histology. We couldn't even look at. We didn't have enough for the others, but it's 14 or almost 15, and then 4 for adenocarcinoma. Now here, instead of the 4-fold difference that we found with the earlier full sample, here we're finding more like a 3-fold difference. Some were not quite 3, but a little bit closer to 3-fold. So that was with the early onset, and then this figure shows the kind of the whole sample, and then our younger, and then again stratifications. So basically showing you the differences there. So conclusions, basically, these risk estimates do reflect, like I said, about a 4-fold higher risk of lung cancer among those who combine the vaping and smoking. But for the early onset, it was closer to 3-fold. We did the separate stratified for men and women, and for the main histological cell types, and again, it was consistently 4-fold higher for the dual vaping and smoking compared to cigarette smoking alone, and then again 3-fold for the early onset. So these results, we believe, illustrate the powerful effects of dual exposure, and contrary to this harm reduction approach that has been used, it does suggest that instead of creating environment that is less favorable, it's actually more, I think I meant to say, is more favorable to the growth and development of lung tumors with the dual exposure. So that this exposure to aerosolized e-liquid may in fact be promoting lung carcinogenesis. But now there were limitations to this study. Like I mentioned, we used this, using the medical record data. That does have its inherent limitations, but we have so much data in there that we try to make do with it. So we're not able to accurately as we like quantify the vaping and smoking. Vaping especially, we didn't get as much. We were able to get some of the pack years on the smoking. So we also just getting more information on duration of smoking, the levels of continuous cigarette smoking relative to cessation, like did they quit and then start again? Did they vape? Did they quit and vape and then smoke? We really want to look at those factors to tease out all these relationships. But we do need more information on these temporal factors, and definitely need future studies. We already have protocols actually, we want to contact these people and to get the actual amounts of vaping and smoking, and then see how this all holds up. But even so, we felt it was important to put it out because they were so high. We wanted to get this information out to just to the public, to people, to doctors. Doctors are advising people on what to do, so they need to know as well. So it's just a really important topic, and we put it out. It had some limitations, but the results were pretty telling. So just in summary, I think I'm ending a little early, so hopefully catch up on time. But these findings do provide the first published evidence that smoking in combination with vaping may significantly increase the risk of lung cancer compared to smoking alone. And that given the high prevalence of vaping and the burden of lung cancer worldwide, we do need well-designed studies that will, with quantifiable estimates of smoking and vaping. They are urgently needed to confirm these results. And, so we would love for more people to look at this, for cancer centers to look at their data, look at their, I've actually talked to people about that, just especially the larger centers where you have a lot of, you have large number of cases, lung cancer cases, to do this type of study if you want to replicate it, and maybe even pull this together. Because one thing we couldn't do was get just the vaping only group. So that was, one thing. And this was through, they're always about a couple years in arrears with the data. So this was through 21. I mean, if we redid this today, we would probably have more cases and more vapors. But again, those records are just limited on the quantity and the duration of vaping. So, so I think I had the one slide is the questions, and but I think those come with the panel. So yeah, thank you, and thanks for allowing me to be here.
Great. Thank you so much, Miss Dr. Bittoni. It's very striking to see there's very high rates of cancer in both the smokers and the vapors. And I think it really just tells us how important it is to try to capture the information, not only on smoking. I think many of us are familiar about capturing pack years, but learning how to capture in our own electronic medical record the amount and frequency of vaping, I think will really help us understand how to better understand the risks there. All right, great. Well, what I'd like to do now is move on to our third and final speaker for this session. The title of this session is Intra-Ethnic Racial Variation in Discrimination and Smoking Among U.S. Latino Adults. This is being given by Dr. Camacho Rivera. She's the Assistant Dean for Student Affairs and Assistant Professor of Community Health Sciences at SUNY Downstate School of Public Health. As a social epidemiologist, her research examines the structural, cultural, and environmental contributors to chronic disease disparities, particularly among Latino communities. She serves as a principal investigator on multiple federally funded training and community health programs. Please welcome to the stage Dr. Camacho Rivera. Thank you.
Right. We made up a little bit of time. I'm going to make up a little bit more time. I don't have to make the case as to why smoking is important. So that helps me. What I'm going to do, I think, is try to make a bridge to some of the earlier conversations that we had in the first session, really linking to and centering structural racism, but also thinking about structural racism as a form of chronic stress and how that influences cancer risk. And so, again, I'm Marlene Camacho Rivera, really excited to be able to present my own research. I'm typically here on the other side of it, moderating sessions. And so this particular work is done in collaboration with students here at SUNY Downstate in our School of Public Health, as well as colleagues at the University of Miami. And so while I am thinking about, again, looking at some secondary data analysis of looking at perceived discrimination and current smoking in US adults, and really centering Latinos and looking at within group heterogeneity with respect to experiences of discrimination and how that influences current prevalence of smoking. So again, thinking about experiences of discrimination, I think it's important to bring it back and center it back into the conversation around structural racism. We can think about structural racism as defined by Dr. Zinzi Bailey and colleagues as thinking about the totality of ways, all of the different ways in which our society really fosters racial discrimination through synergistic and mutually reinforcing systems across a variety of different domains. That could be housing, that could be healthcare, that could be employment, our media, credit, and our criminal legal systems. And so just with respect to thinking about experiences of discrimination, I want to center that sort of in thinking about multiple levels of structural racism. And so you have structural racism, again, thinking about our policies and how our society really differentially reinforces and marginalizes different groups as well as privileges others based off of various identities, and really thinking about perceived discrimination sort of operating at the interpersonal level, right? There's typically multiple players involved. And then, of course, also linking back to some of the work by Dr. Kamara Phyllis-Jones, and also recognizing interpersonal discrimination and really internalized racism. This is, I think, a really nice figure that was done by AACR in their 2024 disparities report that really shows all of the different ways in which cancer disparities are manifested based off of structural racism. So we oftentimes think about structural racism and residential segregation as being the most common proxy that's sort of used to be able to assess structural racism, certainly within epidemiologic studies and in the cancer disparity space, but recognizing that structural racism can really operate across all different domains, whether that be cultural, socioeconomic, behavioral, environmental, clinical, psychosocial, and biological drivers of health, and that these really do manifest in disparities across the cancer continuum. And so we heard some earlier topics thinking about early detection. I'm going to be taking a bit of a step back in terms of thinking about risk reduction, specifically thinking about how perceived discrimination influences smoking. But there's some really excellent work being done by some colleagues. In particular, I want to highlight the work of Dr. Melissa Davis and really thinking about structural racism, linking structural racism to cancer development and etiology. And so why do we need to think about, now that we've sort of set the stage in terms of thinking about structural racism, and certainly our prior presenters have done a great job understanding the need to think about smoking and its influence in cancer risk. Why think about smoking among Latinos? I think oftentimes folks, when they think about Latinos, oftentimes you position yourself in terms of thinking about the Hispanic health paradox. Anybody heard of Latino health paradox or Hispanic health paradox? Sort of thinking about how, in spite of the fact that Hispanics or Latinos oftentimes have greater risk with respect to socioeconomic profiles, lower levels of education, higher rates of uninsurance, they tend to have comparable and oftentimes sort of better health outcomes or better health profiles than even non-Hispanic whites within the population. And certainly when you look at Latino adults in the United States as a whole, the prevalence of smoking cigarettes is actually lower among US Latinos than even non-Hispanic whites. But I want to highlight the within group heterogeneity. And when oftentimes we look at these broad racial and ethnic categories, non-Hispanic Black, non-Hispanic white, Hispanic, Asian, there's a tremendous diversity that's missed within each of these groups. And that's certainly the case when we think about smoking among Latinos. And so there's some excellent work that's been done by colleagues in the Hispanic Community Health Studies, study of Latino Soul, a study that I was very proud to be a part of in their baseline data collection that looked at and found tremendous variability in smoking based off of country of origin. And so they found rates of smoking highest among Puerto Ricans, and that was anywhere from 15 to 34%. 1 in 3 Puerto Ricans smoking, having a lifetime history of smoking, and that is significantly higher compared to some of the rates that you look at when you're compared to Central or South Americans. Dominican Americans actually among Latinos have the lowest rates of smoking. And I want to additionally highlight some additional areas of concern, and that smoking among Latino young adults is also on the rise. So where we've seen and made some strides with respect to reducing smoking initiation among non-Hispanic whites and non-Hispanic Black young adults, we're actually seeing the contrary among Latinos. And the trends are actually even more concerning the younger that you get. And so we're seeing increases in smoking initiation among Latino young adults. That gap widens when we look at Latinos in high school, and we are seeing the greatest increase in smoking initiation among Latino middle schoolers. That is tremendously concerning when you're also thinking about from a life course perspective, right? And starting to situate back when individuals are actually eligible for screening for many of the types of cancers that we've been discussing. And so, and then you pair that with the fact that even among current smokers, there's a significant literature to suggest that Latinos are actually less likely to initiate conversations with their providers around their smoking status and are less likely to be referred to smoking cessation resources. So it's really important for us to be able to think about really preventing smoking before it starts within particular population. So again, we know that, just to set the stage, we know that smoking is a leading preventable cause of cancer morbidity and mortality. We know that discrimination itself is a form of chronic stress. It's linked to a variety of different risk behaviors, not just smoking, but alcohol consumption and other behaviors that increase risk for cancer. But there's also measurement gaps, and really there's a paucity of literature that really focuses on examining discrimination within Latinos in general, but really looking at specific intersections of Latinos across race and ethnicity. We know that Latino is an ethnicity and that there's racial variation within Latinos. And so what I'd like to highlight is a term that we think about within intersectionality theory around intersectional invisibility, that when you look at individuals that are marginalized or privileged at the intersections of specific social positions, race, ethnicity, gender, social class, oftentimes that literature really doesn't exist. And we oftentimes think about just talking about disparities in these broad strokes with respect to race, ethnicity, gender, social class. We all simultaneously identify and occupy a variety of social positions all at once, and they're all differentially privileging us and marginalizing us in different ways. And so just to think about Afro-Latinos, there are about 6 million US adults, Latinos in the United States, that self-identify as Afro-Latino. And that's about 2% of all US adults, 12% of all US Latinos within the adult population, and that number continues to grow. These are Latinos that self-identify as Afro-Latino. There's oftentimes a mismatch and discordance around Latinos who are racialized as Latino, which is a whole other area of conversation that we can certainly get into. But I want to also think about how this particular study can then influence policy. When we think about discrimination and structural racism is mutually reinforced in policies, right? Policies that exist within our society. And so how policies influence the types of targeted marketing of toxic substances and tobacco products within our neighborhoods. It could also potentially influence availability of smoking cessation resources within neighborhoods. And of course, how do we think about making neighborhoods a less stressful environment for Latinos and other Black and immigrant communities? So we're taking an intersectional lens to this particular study, advancing the work beyond just race, beyond just ethnicity, to look at the different intersections of race and ethnicity, as well as gender identity. And so the particular aims for this study were, again, to look at intra-ethnic racial differences in current smoking prevalence among Latino adults in the US, to look at associations between self-reported discrimination and current smoking, both overall and within intra-ethnic racial groups, specifically US Latinos, and to then assess gender differences in these associations. And I do want to highlight that this particular study really advances the gap, and we're looking at the nexus of racialization, ethnicity, and health behavior. There's only been one prior study that has looked at the intersections of race, ethnicity among Latinos and smoking. That was actually done by my colleague at the University of Miami. And he did not look at differences by gender, which we chose to look at for this particular study. So again, really thinking about that there's a huge opportunity to be able to advance this work, and recognizing that, again, the society that we live in is not just structured by race, it's structured by ethnicity, it's structured by sexual orientation, by gender identity. And so really thinking about how do we bring attention to these intersecting structural determinants, which, if you think about, are the roots of the tree, where oftentimes we spend a tremendous amount of attention thinking about health disparities, which are which bear fruit to this particular tree. So for this particular study, we did a secondary data analysis, a cross-sectional secondary data analysis of the National Health Interview Survey. The 2023 data were the most recent data that were available at that particular time. And based off of the eligibility criteria, individuals who had current smoking status, as well as had answered questions around measures of discrimination, our full analytic sample was about 26,000 individuals that, when weighted using survey weights and Strata and the primary sampling units, is weighted to about 222 million adults. So the National Health Interview Survey is one of the surveys that, when you hear about data, when you hear statistics about US adults, this, along with NHANES and some others, are some of the nationally representative surveys that we have. And we chose the National Health Interview Survey because it specifically asked questions around everyday experiences of discrimination. And so our primary outcome was current smoking and based off of self-report. They did have other measures of smoking, which we do plan to, again, further interrogate in the future, but we wanted to start off just looking at smoking prevalence. Our primary exposures were twofold. We were looking at everyday discrimination scale. This is a modified shortened version of Dr. David Williams, who was one of the senior author on that first paper that looked at racial differences in smoking among Latinos. And really, this particular survey measures frequency of experiences that individuals report being treated differently based off of their race in a variety of different areas. To what extent are they treated with less respect or courtesy? Do they feel like they're receiving poorer service? Are they treated as not being smart? Are they seen as being someone to be feared? And are they seen as someone who is threatening or harassed? And then again, we also wanted to look at differences and intersections with with discrimination, as well as race, ethnicity. And so for our particular groups, we looked at non-Hispanic whites, we looked at non-Hispanic blacks, we disaggregated Latinos to white Latinos and black Latinos, and then we also looked at American Indian, Alaska Native, and Asian American adults, and we adjusted for a variety of different covariates that are based off of the existing literature with respect to looking at differences in discrimination, as well as influences of smoking. So age, gender, sexual orientation, marital status, interview language, whether the interview was conducted in English or Spanish, urbanicity, whether they were residing in rural or urban communities, nativity, whether they were born within the continental US or outside of the continental United States, educational attainment, employment, income, and health insurance status. Again, this being a secondary data analysis, we're limited to existing variables, but I think we did a pretty good job of capturing all of the relevant variables that were within the data set. And then for our models, we fit a series of modified Poisson regression models, recognizing the fact that smoking is fairly common and is going to vary across our different groups, with robust standard errors to be able to estimate prevalence ratios. So comparing percentage increases in the prevalence of current smoking across different levels of discrimination, adjusting for all of the covariates that I mentioned on our last slide. And so our primary model, we first fit the effects of perceived discrimination as well as race, ethnicity, and then subsequently adjusted for all of our covariates. We did look at potential interactions by race, ethnicity, and discrimination because of the suggestions in prior literature to be able to look at differences in experiences of discrimination among non-Hispanic blacks compared to Latinos or compared to Asian Americans, all in reference to non-Hispanic whites. And in our initial models, we did see evidence that there were differential associations that were patterned by gender. And so we did fit stratified models for men and women. And just to start getting into some of the headlines. All right, so within this particular wave of the National Health Interview Survey, 11% of all participants were current smokers, and almost 56%, more than half of US adults reported experiencing some form of discrimination of any perceived discrimination. So again, we looked at the frequency, but the overwhelming majority of US adults reported having experienced some form of discrimination in their everyday life. And what you can see is the most common form of discrimination that was reported was being treated with less respect compared to counterparts. Others reported receiving poor service, being treated as not as smart, and less but still important, feeling that they were threatened or harassed, as well as treated as being feared. Now, with respect to looking at differences across race, ethnicity, this was surprising to me that Latino adults actually reported the lowest rate of any form of discrimination at 48%. This was particularly interesting because some of the other work that had been done, specifically looking from the Hispanic Community Health study of Latino Soul, that is sort of the largest epidemiologic cohort of Latinos that we have within the United States. 80% of participants within the Soul study reported experiencing discrimination at some point in their life. There are some differences with respect to the measures. The measures within the Hispanic Community Health study pick up both overt and subtle forms of discrimination, microaggressions. Sometimes we would often think about calling them. These are oftentimes seen as more overt forms of discrimination. This actually led a group of us to be able to think about how do we, rather than adapting forms of discrimination and measures of discrimination to Latino populations, initial measures of discrimination were not developed within Latino communities. They were adapted to Latino communities, actually working with some colleagues at the University of Maryland who have an R01 to be able to actually develop a true community-driven, Latino-driven measure of discrimination. And that proposal is still funded and ongoing. So there should be some interesting results that we'll be able to compare to with respect to differences across measurements and some of the other established measures. But we did see confirmed in other studies that Black adults did report the highest prevalence of any form of discrimination. So what did we see when we looked at our fully adjusted multivariable models? We did find that perceived discrimination was positively associated with current cigarette smoking. So for every 1 unit increase in reports of measures of discrimination, we found a 4% increase in the prevalence of current smoking. We did find that non-Hispanic Black adults had a significantly lower prevalence of current smoking, as did actually white Latino adults compared to non-Hispanic whites. This, again, is something that is pretty consistent with other forms of literature. And we did find that women also had a lower prevalence of current smoking than men, and that smoking prevalence increased as we among older age groups compared to our youngest age group. And again, we did find that adults outside of the United States, born outside of the United States, did have a lower smoking prevalence than US adults. And we saw that, again, there was a clear educational gradient that was confirmed where higher levels of educational attainment were associated with a decreased prevalence of current smoking. And so, again, much of these findings were not particularly surprising. This is when we looked at the full sample of men and women together. What did we find when we looked at when we did our stratified models for men and for women? This is where we found some interesting findings. So among men, again, we did find that perceived discrimination was positively associated with their current cigarette smoking. Non-Hispanic Black men and Black Latino men had a lower prevalence of current smoking than non-Hispanic white men, and that we found that white Latino men and Asian American men did not statistically significantly differ from non-Hispanic white men, and we did find that there were some differences in by marital status as well. When we looked at women, again, we found that perceived discrimination was positively associated with current smoking, and that compared to non-Hispanic white women, non-Hispanic Black women and white Latina women once again had a lower smoking prevalence, but Black Latina women had a higher prevalence of smoking, current smoking compared to non-Hispanic white women. Again, this is a prevalence estimate about 27% higher. Confidence intervals actually look pretty good compared to non-Hispanic white women. This is a group that has not been previously studied within any nationally representative survey so far. We did again see that the age gradients were strong, and we found some differences in marital status and differences in protective benefits of marital status for women compared to men, which are other things that we've explored with various health outcomes in the existing literature. We did also see some differences in our covariates and patterns of association. Some of them were maintained for both men and women, and some of them differed based off of gender. And so again, we saw protective effects of education where there was a lower prevalence rate of current smoking with higher levels of educational attainment. That was consistent for men and women, as well as foreign-born status being protective and having a lower prevalence of smoking for men and women. We found that conducting the interview in Spanish, which is the best proxy that we had available for things like language access, language proficiency. Acculturation was not something that was considered within that survey, but that there was a lower prevalence of current smoking among women who preferred to conduct the interviews in Spanish versus English. And so what does this really tell us? Well, it tells us that we did find that discrimination was robustly associated with a higher smoking prevalence for men and for women. We did find gendered differences, right? So we found differences specifically among Black Latina women who were reporting discrimination having a higher prevalence of current smoking, right? Compared to white Latina counterparts, compared to non-Hispanic Blacks, compared to non-Hispanic white women. And so really thinking about what does it mean with respect to our policy landscape to be oppressed across things like racist policies, xenophobic policies, as well as sexist policies in this current landscape. And what does that mean with respect to how we can target smoking cessation, tobacco prevention, as well as stress reduction supports for Afro-Latina women? And then again, recognizing that some of the differences that we may have not been able to capture during men, we saw some trends that were approaching significance, but really thinking about how we can prioritize increasing our sample size and sort of measurement refinement to make sure that we're truly capturing discrimination within Latinos. Of course, with any particular study, there's limitations. It's cross-sectional, secondary data. This is all limited to self-report. This scale, again, is validated, but again, depending upon the particular items and pulling out certain items, it's sort of unstandardized and really has not been used as very often among Latinos, certainly for this purpose. And again, we saw some small sample sizes for certain subgroups, and there's always the potential for residual confounding with respect to variables that weren't captured within this overall data set. But our next step is to really think about how we can pull these data on other iterations of the National Health Interview Survey to be able to continue to look at some of these differences and expand from current smoking to past years and lifetime history of smoking. We're really excited to be able to start to explore, bring it back to a policy landscape to look at some political determinants and drivers of some of these racialized, ethnic, and gender differences. And my colleague in Miami has funding to be able to work with CBOs, Latino-based CBOs in Miami, to be able to look at how their experiences around targeting marketing within their landscape, as well as differences in smoking cessation support and uptake within Latino communities in Miami. And so with that, I just want to acknowledge my collaborators, Dr. Kasim Ortiz at the University of Miami, and our doctoral student, Kenny Escobar, who's collaborating on this effort, and also acknowledging our transport endowment here at SUNY Downstate for supporting Kenny's participation in this project, and look forward to taking questions in the discussion. Thank you so much.
Wonderful. Well, I'm sure there'll be plenty of questions for our panelists. I'd like to invite all the panelists up, please. Take a seat here, and I'll turn the microphones for you guys. All right, I think there's some microphones that are being passed around. If you could just raise your hand, one of the assistants with the microphone will come right to you. See one in the middle.
Hello, my name is Haraprasad Mandal. I'm coming from Northwell. I'm a postdoc researcher in Northwell. So I'm just 2 years here in USA. Okay, so my question is like, to Aman Man, so how genetic testing can help in early detection of cancer?
Can you hear me?
Yeah.
Okay. So essentially knowing if you have an inherited mutation, we know you're at an increased risk of developing certain types of cancers over your lifetime. So if we can find the gene mutation and know what the associated cancers are, we can actually follow you more closely for that. So it could be either through getting more screening, using modalities that you weren't using previously, doing it more frequently, and the goal being that we're catching cancer early. So if we find cancers at an earlier stage, there's better outcomes. And some of the options that we have available are preventative. So colonoscopies, if you do them regularly for a high-risk patients that have polyposis syndromes or colon cancer syndromes, if you remove those precancerous polyps, you're reducing that risk of developing a cancer in the future. Or those surgeries that I talked about, like risk-reducing mastectomies, removal of the ovaries, uterus, these are all preventative methods.
But in the previous talks, like we have seen that most of the speakers, they have said that cancer cannot be, in general, it cannot be detected at the early stage. It comes after, late stages. Mostly the data that they have shown.
True,
So,
but some of
but
it
you are
has
doing
to do-
genetic testing for the early detection of that. So it's not like both things are going in a different direction.
So some of the cancers that are found in late stages are due to just access and them getting the care to get the screening to be able to be diagnosed. So we talked a lot about people not getting their colonoscopies, not getting their mammograms, not going for cervical cancer screening. So they're showing up much later. If an individual knows that they're high risk, hopefully, and most of the patients, we encourage them to get their screenings done more regularly because their risk of developing cancer is so much higher that they need to be watched more closely. Do we sometimes still find cancers at late stages? Of course. but at least then we know what we're looking for. We can't look for something we don't know about, right? In general population, we're not screening for pancreatic cancer, but if you have a gene mutation that's putting you at risk for pancreatic cancer, we can link you with the pancreas program, like with Dr. King, and make sure that you're being followed.
Okay, thank you. I just want to say, like, it was a great talk, all of you, like, in this panel. It was high speed, huge speed. Okay, so my next question is, like, the vaping and smoking for Marisha Bettoni. Yeah, so thanks for coming back to New York after six years of COVID.
I know.
Yeah.
It was just bad weather yesterday.
Yeah.
And snow, but that's okay.
I just want to know, like, what difference does it make in smoking and vaping? Because you said, like, there was no study, a difference between smoking and smokers and the vapors. So how does it make a difference? Like, because I'm not a smoker, I don't have any idea, like, how difference does it make from the smoker and a vaping machine, like, whatever?
Yeah, you mean what is like the difference? How does it affect like
Yeah.
risk and lung cancer?
Yes,
or-
exactly.
Oh, okay. Yeah. Well, like I mentioned, I think in the talk, the smoking is when you smoke, it's like combustion because you light that and it's like, so you get the smoke, you inhale that smoke and it, goes through every cell. I mean, every cell of your body. I mean, smoking really is, increases just about every type of cancer, increases risk of just about every type of cancer because it infiltrates everything. Now, whereas vaping, you've got this aerosolized liquid that is, it's a steam. It's going into your lungs. I don't know if it's been studied as well, as far as that exact mechanism of how, but it's still, that vape, that steam is, circulating. It's definitely going into your lungs because you're inhaling it just like smoke, but the smoke infiltrates everything. And, I think smoking has more carcinogens, but, the vaping does too. I mean, the vaping has the nicotine, but, it is a different mechanism, but, with the vaping, then for a while there, you heard of popcorn lung. So that was I think that was link to a specific like flavor or specific type. So they changed that. They got rid of that and didn't see. But it's definitely causing that inflammation and that those increased cytokine and inflammation.
Yeah.
So so I'm not sure the vaping is exactly known as much as the smoking. We're still learning about it, of how it works. But the fact that those risk ratios were so high for the dual. So, there's something going on, and it's like I said, it's almost like a synergistic or effect. Yeah, I think so.
Thank you.
More to learn about it. Thank you.
Okay, my last question to Riviera. Okay, Marlene. Okay, so in one of the slides you have shown that the Latino women, they're more smokers, like the percentage. Am I right?
Black Latina women, yes.
Yeah, as compared to the
Non-Hispanic white.
yeah.
Yes.
So white, the men. Okay, but the question is like what in the previous slides that we have seen. I don't know exactly that how I'm able to correlate like what Dr. Bettoni has said, that the women are less prone to get lung cancer. In one of the slides you have shown that. That as compared to men. Am I right? Yeah, Dr. Bettoni, yeah.
Oh, I'm sorry. What was that?
In one of your slides, you have shown that the women are, the percentage-wise, they are less prone to lung cancer as compared to the men.
It's gone up actually in women more. It's in recent years. It's actually increased in women.
Yeah.
But I will say that when I did another study where I looked at inflammation and the women and the men and the smoking effects. It was much more prevalent in the men. The women were more, the smoking didn't matter as much with them as you even see in what I showed today. So I think with the women, it seems to be more perhaps environmental or genetic, at least, so far. Yeah.
So if I correlate like, that women are smoking more, but they're getting less cancer. So indirectly,
it's not necessarily due to smoking. They're getting more cancer, but it's not necessarily due to smoking.
And oftentimes when you're looking at associations that are showing gender differences in lung cancer or other types of cancer risk, again, you're aggregating that and creating averages across broad populations. And so what that does is that you're missing subgroups that are at higher risk, because you're taking individuals who have low risk and high risk, and you're showing that there's, that there's a net sort of average, right? So everybody is the same. And so what, again, I think the study was really showing that there are specific subpopulations that are at high risk that are not really being, studied within the literature because of a variety of different, limitations. It could be limitations with respect to how we capture race, ethnicity, how we capture country of origin within existing data sets. It could be contingent on the population, right, that you have available within your cancer catchment area or within your service area. My deliberate intention of showing this particular study is that we here in Brooklyn and in New York City are uniquely positioned to be able to also advance this work, and given the populations that we serve both clinically and publicly, have a responsibility to be able to help to advance this work forward and translate it into community and clinical interventions.
Thank you.
You're welcome.
If I could just add to that, so our population was 88% white, but if we, that's why I've encouraged these other cancer centers, and especially if they can get more diversity, and then we could get more information through other populations.
Okay, so to keep us on track, we're going to take one more question. Please go ahead.
Good afternoon, everybody. Hello. So I'm not from healthcare. I'm an AI engineer, so might be my question is silly, but I'm very interested with genetics because being an engineer, so I love data. Specifically, when you talk about Northwell, you guys are doing this and have a people. So I'm very curious, what is the best practicing? Are you guys using AI or genetic AI? Because right now, how you guys are doing this, because it's a lot of data, history, family history, other medicine testings, all these things. So is there any best practicing? Are you using AI?
Great question. I think AI is going to be in everything anytime soon, if it's not already. Data holding in terms of genetics is a big issue. What we're doing with it, where we're holding it. Right now, we don't do in-house testing at Northwell for germline genetic testing, but we did just create a lab, and hopefully we'll be doing it in-house, and then we'll have to figure out how to hold all that data and be able to use it for research. But our labs that we do send out to, these third-party commercial labs that do our germline genetic testing, have started using AI more so for data curation and variant curation. So once they find all these changes, they're using AI to help kind of bring it down to the ones that are really concerning, and then classifying them as pathogenic or benign, or helping with that process. But how exactly it's happening, I'm not sure. I'm not an AI engineer, and I don't use it as much.
I will jump in and just say that we are using AI as a social epidemiologist. I think that one of the most exciting things that we do, there's a lot of unstructured social determinants of health data that's captured within clinical notes. And so things related to experiences of discrimination, stigmatizing language that's used within the healthcare context. And so working very closely with data scientists and computer scientists, not only to be able to look at how we can tap into some of these social and cultural factors that are being used in unstructured clinical notes, but there's a huge initiative to be able to push for screening for social determinants of health, right? Using standardized tools like Prepare. And I would welcome the opportunity to talk to you further, because we're doing some interesting work in multimodal AI and thinking about how we can leverage geospatial imaging to be able to further contextualize neighborhood and structural racism with respect to cancer risk. And so it's an exciting time, but there's always the potential to leave communities behind when you're thinking about who has access to AI data science tools, and then how that gets translated back into either clinical decision-making or shared decision-making at the public health level.
Thank you. That was my follow-up question, how somebody externally come to work with the guys. Thank you, I appreciate it.
Okay, let's do one final round of applause for the speakers, please. That was a fantastic session, and a lot of food for thought. And sure. Yes. So, thank you, Dr.
Sure. Okay, so that completes our morning session.